We're going to think now about how hemorrhage and the shock that hemorrhage causes is classified. And we're going to base these figures on an idealised 70 kilogram man. But that's a man who should weigh 70 kilograms. So if someone's a particular height but they're quite obese, then we're going to base it on their ideal body weight rather than their actual body weight. And we do that because fatty tissue is not well perfused. So we're going to estimate it based on their ideal body weight rather than what they actually weigh. Now, blood is about 7% of body weight. That means that in a 70 kilogram man, there's going to be about 5 litres of blood. Around about 5 litres of blood. And we're going to base that on ideal body weight. And the reason I want to do this classification particularly is so that we can recognise clinical features at an early stage and treat them before the shock becomes established. Because the earlier we treat significant hemorrhage, the better the outcome is going to be for the patient. And we're going to look at blood loss in mils as one criteria, blood loss in terms of percentage of the total blood volume that that patient has, their pulse rate, their blood pressure, particularly their systolic blood pressure, that's the first one, but also the pulse pressure. And the pulse pressure is the difference between the systolic and the diastolic blood pressure. So at 120 over 80, 120 systolic, 80 diastolic, the pulse pressure is going to be 40 millimetres of mercury. That's an important indicator. We're going to look at respiratory rate, urine output, mental state as a proxy for how well the brain is being perfused with blood, and we're going to look at the implications of that for fluid replacement. And the first classification, obviously, is class 1 hemorrhage. So in class 1 hemorrhage, the blood loss would be up to 750 mils. No more than that. And that represents a percentage of blood loss of up to 15%, no more than that. All other things being equal, with this degree of blood loss, the pulse rate in a reasonably healthy person should still be less than 100 beats per minute. So we're not going to get a profound tachycardic response with this level of blood loss. The blood pressure, the systolic blood pressure, will still be normal. They're not going to drop their systolic blood pressure as a result of this degree of hemorrhage. The pulse pressure will probably be normal, or it can even be increased. What I've actually said here is that hemorrhage can cause an increase in diastolic blood pressure. That's rather strange, isn't it? But what's actually happening here is that when the patient starts to lose blood, the sympathetic nervous system is going to stimulate the adrenal medulla to produce catecholamines, adrenaline and noradrenaline, or if you're in the US, epinephrine and norepinephrine. And they're going to be vasoconstricting. And that's going to actually raise the diastolic blood pressure, or it can do. So even though the systolic blood pressure stays the same, the diastolic blood pressure can be raised, and you can see that's going to narrow or lower the pulse pressure. So actually, narrowed pulse pressure can be one of the very first indicators that a patient is bleeding from somewhere. Respiratory rate, well, of course the patient might be anxious, but we can count 14 to 20 as a normal respiratory rate. Urine output, normal urine output of greater than 30 mils an hour would be expected. That's still normal. Mental state, well, even slight class 1 hemorrhage can cause the patient to feel anxious. And again, anxiety is one of the earliest features that the patient's blood pressure is dropping. So after bleeding, or indeed any other cause of low blood pressure, one of the first clinical features that can happen is the patient feels anxious. Anaphylactic reactions are classic for this, where the patient gets this horrible sense that they're about to die, this feeling of impending doom. So anxiety, always worth asking if your patient's anxious. Fluid replacement at this stage, if we're going to go for an intravenous one rather than just giving them drinks, would be a crystalloid intravenous fluid replacement. So we're now thinking about class 2 hemorrhage, and this is going to develop when the patient's lost between 750 mils and 1.5 litres of blood. So it's a much more significant hemorrhage because this represents a blood loss of 15 to 30% of the total blood volume. And the pulse rate in this case, as the tachycardic response develops, we would expect to be 100 to about 120. Now, even at this stage, the systolic blood pressure can still be normal as a result of the compensatory mechanisms. The systolic blood pressure doesn't really change in the early stages of a developing shock. So at this stage, I would say the patient is shocked because they've got these responses, but the blood pressure is still normal. And the pulse pressure can still be decreased, it can still be less than normal because of the catecholamines, the adrenaline and the noradrenaline contracting the small blood vessels, maintaining or indeed increasing the pulse pressure. So the pulse pressure has decreased, not because the systolic pressure has changed, that's still normal, but because the diastolic pressure has increased. And the increase in the diastolic pressure has caused the decrease in the pulse pressure. Respiratory rate now is increased, well above normal, 20 to 30 breaths per minute. The patient is now tachypneic. The urine output can still be reasonably well maintained. It's probably just going to drop a bit, so 20 to 30 mils urine output. Although with that, I would say that this patient is now in an acute renal failure. If it's less than 30 mils, probably they're getting into acute renal failure territory. Mental status, well, the patient's going to be more anxious, agitated, maybe even hostile. If a bleeding patient is hostile and bad-tempered towards you, don't hold it against them. It can be because the brain is not being properly perfused with blood. And the fluid replacement we want to give is a crystalloid intravenous fluid, warmed. That's what we would look for to diagnose a class 2 hemorrhage. We're now thinking about a class 3 hemorrhage. And things are getting serious now. This could be complicated by significant organ failure effects, and it can have a devastating effect on the patient. This patient is in danger. They need fluid resuscitation, and we need to find out where they're bleeding from and stop the hemorrhage. It's an emergency situation because this patient's lost 1,500 to 2 litres of blood. We're starting to approach life-threatening territory at 2 litres because that's a percentage blood loss of 30 to 40% of their total volume. The heart's trying hard to compensate with a tachycardic response, which you might expect to be 120 to 140. And now, for the first time, the systolic blood pressure is reduced. There is so little blood left in the circulation that the patient cannot maintain their systolic blood pressure, and they are now becoming hypotensive. So they've been shocked for a while. In class 2 they're shocked, but now they're really getting badly shocked because the blood pressure is going down. And always remember that hypotension is a very serious, ominous development in the progression of shock. Ideally, the patient would not have got to this stage. We would have treated them early. But if they have, they have. And the pulse pressure is decreased now. Okay, the diastolic pressure might be maintained, but now the pulse pressure is decreased because the systolic pressure has come down towards the diastolic pressure, decreasing the pulse pressure. The respiratory rate is high, 30 to 40. The urine output is now starting to crash down quite a lot as well. The patient will become anxious or even because of the cerebral hypoxia. And now, as well as giving crystalloid, this patient may well need blood in addition. Because remember, 98 or 99% of the oxygen that is carried in the blood is carried by the red blood cells. So we might now need to start replacing red blood cells to restore the oxygen carrying capacity of the blood. Class 4 hemorrhage can be considered as a pre-terminal event without immediate intervention to give fluids and to stop the bleeding. These patients are about to die. They have exsanguinating hemorrhage. They are very cold, probably clammy, pale, and these are the criteria that we're going to look at. So these patients are really pre-terminal. This is absolute last chance saloon to do something to save these patients' lives. Stop the bleeding, get some fluid back in, otherwise probably within a few minutes you're going to lose these patients. Because in class 4 they've lost 2 litres of their 5 litres of blood, assuming they're this 70 kilogram man whose ideal weight would be 70 kilograms. Blood loss now greater than 40%, immediate life-threatening. Pulse rate, while the heart's doing all it can to compensate, probably greater than 140 beats per minute. The systolic blood pressure can be significantly reduced. The pulse pressure will be massively reduced. The respiratory rate will be very fast, very tachypneic. Urine output doesn't matter too much because without treatment these patients are going to die anyway, but it's going to be negligible. The kidney is not being perfused. The mental state, the patient now will be confused, lethargic, and if a patient loses any more blood, they'll become unconscious. We say if a patient loses 50% of their blood, they're going to be unconscious, probably immediately before death. Fluid replacement, absolute emergency. Crystalloid, fast, into both arms with a wide bore cannula. And of course, if available to you, blood, possibly type specific or O negative. Last chance to save the patient's life. So I've just put that all together in one table. Class 1, Class 2, Class 3, Class 4, and we'll just leave that on for 5 or 10 seconds so you can freeze frame it if you want to look at it in more detail.